Okay. So am I coming through okay there?
Yes.
Okay. Hi, everybody. My name is Dr. Wayne Bentham. Um, I am a psychiatrist and I am a consultant for the CLearn project. And I will be doing 4 weekly sessions with you over the next month on mental health and resilience. And today's first session is going to be focused on what's called the collaborative care model for the treatment of depression. I will address, my plan is to address any questions that you may have at the end so that we can have more of a discussion after the presentation. As I'm doing the presentation, I'm pretty sure that you guys are going to have maybe some CLearn specific questions that I will do my best to answer to the best of my knowledge. Otherwise, I'll rely on Ashley to address those as well. Okay, so one of the main goals of CLearn is to make sure that people and communities build resilience and recover from disasters. And so the collaborative care model approach to addressing mental health on an individual and a community level has been shown to be pretty effective and very effective in delivering mental health services, particularly in resource-challenged environments. In our session today, I'm going to present to you what is the collaborative care model, an approach for implementation of the collaborative care model for organizations given current resources, and the tools that you will have to implement the collaborative care model as part of the CLearn collaborative. So the development of the collaborative care model back in the day basically came from taking a close look at how patients in primary care access care for depression. And so there were a few things that were noticed. The first of it is most people in the community, if they're struggling with depression or anxiety or some sort of mental health issue, they'll go see their doctor or their primary care provider, as opposed to walking into a community health center or coming to see someone like me, because that's where, you know, folks are kind of culturally taught to receive initial care for any problems that come up. Over time, it was found that for the majority of people who did show up to their primary care provider to get care for depression, that it was effective. For some, it was somewhat effective, and for others, it was not as effective because it was actually discovered that they were having other mental health needs as well. And so the traditional way for primary care clinics or a primary care provider to address this was to send a referral for specialty mental health care, whether that was directly to a specific psychiatrist or psychologist or therapist, or whether that was to a community mental health center. The challenge with that, though, is that one, there's usually limited availability. Two, the referral process wasn't very consistent. And what it meant was that three, it wasn't uncommon for patients to actually get lost in the system or lost to follow-up even before getting seen for an initial evaluation. So the idea about the development of the collaborative care model was basically to ask the question, what if we were able to bring specialty mental health care services into a primary care clinic? Now, historically, the first way of doing this was something called co-location. And what that meant was actually placing a consulting psychiatrist or a psychotherapist or a counselor in a primary care clinic, and if a patient came to the clinic with those issues, refer that person to the mental health care worker. But what was found over time is that while that person was now in the clinic, some of the same accessibility issues remained. Some people didn't follow up with referrals, or if they did follow up, they didn't follow up consistently, and so some people again got lost in the cracks. So the whole idea of the collaborative care model was to introduce someone called a care coordinator whose sole job it was to actually make sure that when that referral happened, that patient showed up, and also to track any sort of care when it came to depression. Now, the very first large randomized controlled study for the integration of a care coordinator was a study called the IMPACT trial. And that looked at the treatment of depression in elderly patients in primary care. And it actually looked at what was the effect of actually introducing this person called a care coordinator into the mix when it came to treatment of depression in primary care. Literally what this person did, what this meant was a care coordinator who was someone who was trained in kind of the specialty management of depression. They was trained to screen for depression. They were trained to keep track of depression outcomes, but they were also trained in certain forms of psychotherapies and also certain forms of other techniques to help a person actually improve from depression in primary care. This care coordinator was actually located in the clinic and was readily available if someone went to see their primary care provider. The primary care provider did an initial diagnosis of depression. And so once that happened, not only was treatment started, but the primary care provider directly connected this person to the care coordinator and said, hey, this person is going to be following you in between appointments until I see you next time to see how you're doing. It was then the care coordinator's job to make sure that that person followed up with appointments, to make sure that they track depression outcomes, to make sure they're responding to care. If this person was not showing up for appointments, actually doing a phone call and making sure that there were other things that were going on. And in addition to the they also had these specialized skills that they were given in terms of doing some brief psychotherapies for depression in between visits. This care coordinator was also supported by a consulting psychiatrist who actually was not on site. But the consulting psychiatrist and the care coordinator had regular times that they would speak by telephone or by video chat or whatever communication to actually talk about the care that a care coordinator was giving to a particular patient, get the consulting psychiatrist expertise to take a look at that and make some recommendations. And it was the care coordinator's responsibility to communicate those recommendations to the primary care provider before the next appointment, so that by the time that next appointment happened with the patient, that primary care provider was actually very well prepared with what happened in between visits and some possible recommendations to actually do with the patient to try to improve care. So this IMPACT trial that I'm telling you about was a randomized control trial that take a look at doing this intervention. And they looked at, they did this with about 18, I think there were about 1,800 patients in the study. And it was pretty much shown that having a care coordinator like this, supported by a specialist like a psychiatrist in this type of model, actually brought about improvement in every patient that went through this intervention. Since then, there have been several other studies that have looked at this collaborative care model that have, at this point, actually shown that having someone whose job it is to make sure that a patient is actually getting the care that they need, supported in this way and integrated in this way, actually is very effective. So one can imagine then that a given care coordinator in this situation, in a particular organization or agency, including a primary care clinic or a community health center, is following the care of a number of patients or clients. Typically, in order to help the care coordinator keep track of what's going on, this care coordinator is going to have some way of actually recording data for each one of these patients and collecting that data in a registry over time. And the helpful thing about this is that after a period of time, it becomes very easy to quickly identify folks who may not be doing as well for whatever set of reasons, whether it's they're not responding to the treatment or they're not taking the medication or the medication is not the right one, or they're not able to show up to appointments for transportation reasons, whatever it is. This system actually, with the registry and the collaborative care model, allows the care coordinator to actually quickly recognize folks who are not doing as well so that no one actually falls through the cracks. And so it was realized pretty quickly that this model of care was very good at efficiently identifying folks and making sure that people didn't get lost to follow-up, or at least not lost to follow-up for lack of trying to follow up with them. Now I'm going to emphasize here that the typical way that a care coordinator would actually follow up with patients in between visits are one of two ways, usually by telephone, or sometimes a person would actually come in for an appointment with a care coordinator. So this is why a care coordinator's role is actually a very specific job. It's not something that's tacked on to something else. I mean, this person actually has a very set set of responsibilities and things to do, and is expected to actually carry a certain caseload of people. So this is actually a full-time, full-time work to do. Now, the other thing about the collaborative care model is that the care coordinator can also then become a kind of the transfer point if a particular patient or client has a number of other people involved in their care. So on this slide, the example here is that here is someone, a patient who has involved in their care, a case manager, an addiction specialist, a therapist of some sort, or maybe a home health giver. And if this care coordinator and the patient actually have a close relationship and all the legal permissions are done, this care coordinator can become kind of the hub for making sure that a person follows up with all of these appointments, or getting the sense of what progress this person is making through all this kind of care. So all of this can be then communicated to the primary care provider, which then can be used to actually make clinical decisions when the person shows up for the next appointment. So the beauty and the simplicity of this type of model is we have preserved this relationship between a person and their primary care provider, and we've introduced to that relationship someone whose sole job it is to actually keep track of a whole lot of things very effectively to make sure that the decision making that's done here in the clinic is actually done efficiently and is well informed. So over time, as I mentioned, there have been a number of studies that have looked at the collaborative care model. And specifically, the collaborative care model has been studied for the treatment of depression, anxiety, PTSD, bipolar disorder, chronic pain, diabetes. And it's also been used to look at how this type of care can be done in primary care, various settings, whether it's primary care, cancer care, diabetes care, chronic pain, and even post-disaster. In fact, one of my first experiences with providing collaborative care was actually with the Reach NOLA project, which happened, a few years after, like 2 or 3 years after Hurricane Katrina, that some of you may have been involved in, where we actually did this on a community-wide level. And it was actually shown to be, pretty effective. Again, if you remember nothing else about this discussion about collaborative care, there are 2 things that the collaborative care model has been shown to do effectively. The first is to coordinate care between different sectors of a person's life or services. And the second is to keep track of folks in an efficient and proactive manner so that no one falls through the cracks. The hope and the expectation with all this, of course, is that any person who is receiving services in this way in a collaborative care model has the experience of being surrounded by and effectively cared for by clinical services and also by community resources. And this in some ways is what we can see as one way of representing community resilience. Now, this is a person who is well connected to primary care services through a care coordinator, and at the same time well connected to community resources through that same coordinator if need be. Now, I've so far spoken about this mostly from the bottom up, or from the patient or the client side up. The other thing to realize is that in order for this type of work to be done well in any sort of organization, there's actually kind of some background that needs to happen. In my experience, in order for this model of care to be successful on the patient side, there's a lot that's necessary on the clinic or agency or organizational side in order to make this a successful process. To be sure, or to understand this, the collaborative care model is still very different than the traditional model of care delivery. And by definition, the collaborative care model is very focused on working across traditional boundaries and silos in healthcare. And for a lot of organizations who are decided to take this on, this can be very much a cultural shift. And it's a cultural shift that really requires everyone at all levels in the organization to be aware of and to work through. So some of these cultural issues can include not only focusing on costs, but also focusing on outcomes. Focusing on outcomes as well as functional results of care. balancing satisfaction with care against the external review measures that a lot of organizations are responsible for on a quarterly or annual basis, and redefining goals for satisfaction versus costs and versus outcomes. I like to, in my experience in doing trainings and working with organizations to do this, the leadership very much has to be on board with the idea that even if it's just the mental health sector of the services that they are providing, that this is going to be a very different way of doing this, and that a lot of people on the front lines, meaning primary care providers and even the consulting psychiatrists, are going to be a little bit resistant to this because it kind of flies in the face of traditional ways of delivering individual care. But the whole idea here, though, is that if we're going to have a system where we have a paired practice team who is having a productive interaction with an activated and informed patient or client, that there's certain things that need to be in place. And so I'm going to talk some about that as well. One way to think about this cultural shift is for a clinic, an organization, or agency to imagine that each of the clients that they serve exists on the boundary of clinical service need and community support. And from this perspective, we can then begin to see that these pieces could fit together and that there are a possibility of roles that are based on current resources. So the way I've represented it here is to actually necessarily say that this case manager or care manager that I've been talking about kind of exists on the same boundary as the patient. And this care manager or case manager then has access on both sides of this model, the clinic side and the community side, to actually make sure that services are coordinated and integrated. So let's talk a little bit about what it means for administrators to be involved in this type of care delivery. So I actually see administrators of organizations, agencies, and clinics as kind of the collaborative care champions. And what I mean by that is that these are the folks that are really going to be responsible for setting the tone of how that culture shift happens. Directly, it can be as, I guess, simple as that, these administrators saying, not only are we going to take this on, but this is how we provide this type of care in this clinic, so that message becomes consistent with everyone. So it really means that administrators are going to need to be supportive of teams that are developing collaborative care infrastructure and identifying and correcting any system infrastructures or communication issues that are needed. It's going to mean that administrators are going to need to be supportive of aligning collaborative care tasks with people, and we'll talk about that a little bit later. Supporting teams as far as doing case reviews and quality improvement so that the system of collaborative care advances as it starts to get more mature. Supporting growth and knowledge and the attitudes of people that are going to be involved. And that can be anything from making sure that care managers and case managers have appropriate supervision about the work that they're doing, to making sure that the primary care providers are actually educated around providing specialty care like depression care or anxiety care or PCP or PTSD care. It also could mean developing sustainability plans and partnership agreements, particularly, for when we think about what the mission of the C-Learn collaborative is. Agencies may find themselves actually reaching out to other agencies in ways that they haven't before in order to make sure that their clients and their patients are actually getting the best services available. And to promote a culture of hope. In the beginning, when when an organization is going through a transition like this to try to provide this type of care, it can be a bit jarring, on the provider side, because there's a sense that, okay, I'm not really sure how this is going to happen, but I'm going to have to trust it. And I think there's a role for administrators to actually support their providers in knowing that, okay, this is something that we are aware of. It is actually well tested. There's a lot of good data on it, and we can get better of it. The other side of promoting a culture of hope is also promoting a culture of hope for the clients that we serve. we would like to think that when we do this type of work, we can do this in a way that's somewhat seamless, so that we can actually so we can help patients and clients kind of focus on their situations and actually move through the process well. Let's now take a look at the roles and the goals for case managers and outreach workers. And I would say that this is the one place as an organization or an agency or as a clinic where there can be a fair amount of creativity about how care managers, case managers, and outreach workers participate in this type of model. I think, and in my experience, at this level, I think it's actually best sometimes or oftentimes to rather than think of these as specific roles, actually think about these as a specific set of tasks that need to be shared. As an organization or as an agency is trying to figure out, based on the resources that they have, how are we going to participate in this collaborative care model? Let's say you're an agency that already has a really robust case management system, or as well as a really robust outreach worker system. You may find that some of the tasks that we have described that are traditionally done by care managers or case managers can actually be shared, with outreach workers for the sake of actually getting clients in for care and keeping track of clients to make sure that they don't fall through the cracks. I think this is something that CLearn organizations already know how to do. And the difference may be here for this collaborative, maybe with forming different types of strategic or alliances or new partnerships for the sake of making sure that the services that are going to be provided actually get provided in a way that makes sense for the organization. Overall, I think regardless of what the tasks are, I think there are certain values that are important when it comes to doing case management, care management, or outreach work, in the collaborative care model. So one of these, of course, is to promote health and wellness. One of the things that we as healthcare providers sometimes can do, and I think this has to do more so with how we're trained, is that sometimes we can get over-focused on finding what's wrong or what's not working, and sometimes forget that the goal here is to identify what's not working in order to promote health and wellness. So I call that out by way of saying that if we are able to keep that in the forefront of our minds, then I think our approach to how we actually help people through their problems would actually go a bit smoother. The other is doing what we can to reduce stigma. It is the year 2019. It is the 21st century, and believe it or not, in certain communities, there's still a fair amount of negativity that exists out there about what it means to actually access care for emotional and mental health well-being. And I think we, as folks who are going to be involved, particularly if we're going to support community resilience, are going to need to have a certain set of ease with our ability to actually help people access care in a respectful way, but also communicate with the rest of our communities about what it means to actually access mental health care in a way that reduces stigma and therefore reduces the risk that folks don't seek care. One of the ways, of course, of doing this is by making sure that we have a very good referral and educational system for doing this. And by education, I mean that education on all levels, not only education of our clients and our patients, but also education within our organizations about what it means for folks to be struggling in certain types of ways. Keeping in mind and keeping it in the front of our mind that our goal here is to assist people who are suffering, and we're not trying to add to their suffering. And of course, being culturally competent and culturally sensitive as we deliver services in this way. Now, what are some of the activities that case managers or outreach workers or care managers can do in this model? Specifically, screening. So one of the things that we'll be talking about not only briefly today, but more so in follow-up sessions, is the process of screening for certain mental health issues. And what we mean by screening is just basically, how do we go about consistently and reliably identifying people who may be struggling with symptoms of depression or struggling with symptoms of PTSD and or stress? And once we identify those reliably, how do we actually get them connected to care? The other is education, providing, what we think are helpful materials and culturally competent materials to help people understand what may be happening with them and therefore appreciate that there are services that can actually help. Um, Having a system of referrals that is actually robust and reliable. One of the first things that we learn as community health and public health workers is that it makes no use to screen for something if we don't have a process to connect someone to care to get it better. So if you as an agency have decided that you're going to help to screen your community for folks who may be struggling with depression and PTSD, for example, it's going to be important for you to make sure that you have a reliable referral systems for these people to actually get care. The other is client support. One of the things that is very, very important, particularly in the aftermath of a disaster, and I think we're all aware of this, but I'll call it out anyway, is to make sure that a person actually has the reserve and the wherewithal to do the things that need to be done, but also have the wherewithal to actually behaviorally do the things to help themselves get better. There are ways to kind of think about this in very esoteric ways, but there are also ways to think about this in very practical ways as well. And we'll talk about that in future sessions. Advocacy, the whole idea that one of the ways that we prepare communities to be resilient, particularly around unexpected mental health needs, is to make sure that we have a strong system of advocates who are going to make sure that, if Mr. Jones is not able, for whatever reasons, to connect with his primary care provider, that someone is out there advocating for him so that he can connect. And then the other is what I've been mentioning before in a bunch of different ways, is that having follow-up, not only to check a particular client's progress, but having follow-up to make sure that that person who is connected to your organization does not fall through the cracks. Okay, so let's talk a bit now about the roles of community outreach coordinators and community outreach organizations. One of the things that was a real education for me, when I was involved in the Reach NOLA project, was that this was actually the first time that I had actually had in-person contact with things like community organizations who have outreach efforts. And ever since then, it's something that I've become so attuned to in the work that I do on an everyday basis, is how do we actually help organizations with the efforts that they're doing already to kind of to step out into communities and to find folks who need help and to help them do that. One of the ways that the collaborative care model can help reinforce this is actually, again, helping organizations to participate in task force, coalitions, community support networks and councils, developing self-help groups. Again, using that quality of a collaborative care model that forces organizations and people to work across boundaries to create results for people. Helping to identify community health and social needs and creating or initiating problem-solving actions for those agencies. Helping to provide education and consultation, as I described before. Possibly working with care managers to track outcomes and to coordinate care for patients. And we'll talk some specifics about that in a few minutes. And expanding or enhancing the abilities of agencies and groups to respond to health and social needs. And I don't know that there's any more clear example of that than recovery from a hurricane or recovery from other natural disasters, where agencies, in order to do the things that they want to do to help the communities, have to actually find a way to collaborate and work with each other. So let's go back now and talk about some specific roles within the collaborative care model that could be relevant for organizations within CLearn based on the resources that they have. So as far as agencies that may have primary care providers who are going to participate in this, there are a certain skill set that kind of naturally falls there, which is, skills, the skills around the training and support of assessment, treatment, and doing referrals, and of course, providing culturally competent care. Primary care providers are very much involved in tracking those who are not responding as well to treatment as we would expect. And for that purpose, then making sure that treatment plans are changed and updated appropriately, and provide effective follow-up so that patients and clients are find it easy to actually adhere to their care. As far as the consulting psychiatrist who may be participating, in this model, this is the consulting psychiatrist is actually, the evidence-based resource of, what is, what works and what doesn't as far as treatment of mental health and dealing with mental health emergencies. Traditionally, as far as the traditional collaborative care model, the consulting psychiatrist was kind of seen as a resource that was accessed by the care coordinator or the care manager. But there are plenty of models out there for whom a consulting psychiatrist can be available to see patients. And typically, what happens in those situations is that if the collaborative care model already exists in a particular venue or agency, the person that is referred to the consulting psychiatrist is typically someone who's been discussed several times, in the back and forth between the care manager and the consulting psychiatrist. And in that back and forth, I've identified that this is someone who's really not getting better. We need to figure out what's happening. And so by the time this person is seen by the consulting psychiatrist, this consulting psychiatrist actually knows a fair amount about who this person is, what the situation is, what their treatment has been, and what hasn't worked. And so it makes once this visit happens, it actually makes it quite efficient. And the person can still be followed along by the care manager and the primary care provider. One of the things that a consulting psychiatrist does, of course, is, write prescriptions. So there's certain models, in which a consulting psychiatrist will provide prescriptions for treating mental health, supportive treatment plans that are developed. And then the other two roles here is something that naturally falls out of this idea of being collaborative. The consulting psychiatrist can also become a really good resource for primary care providers, in terms of education and consultation about how to treat, certain types of, mental health conditions. In my experience as a consulting psychiatrist, I've worked with primary care providers, surgeons, cancer specialists, and things like that. And one of the most rewarding aspects of that is actually watching these folks who, in the beginning, are somewhat resistant to the idea of managing mental health things, and over time, with enough support and enough experience, actually become quite open and quite easy with some pretty sophisticated mental health decision making. So it is something that is possible and happens over time. And then, of course, thinking back again to the idea that organizations and agencies that provide this type of care have to be very vigilant for how those services are provided, the consulting psychiatrist can become very involved in any quality improvements that needs to be done, as far as further development of a collaborative care model. Okay, now you may be an agency that also has a therapist available for your clients. And as far as therapist participation, this is, someone who is expected, again, to provide services, reduced stigma, very much involved in education and psychotherapy, managing referrals, participating in any sort of collaboration and any supervision of care managers as well, and also supporting any quality improvement efforts. So, regardless of who you are participating in this collaborative care model, I think, again, there are certain values and certain ways of being that experience has shown are helpful in order to make sure that you are providing effective care to people. So, the first is building trust. I don't know of any other more important or critical situation in terms of building trust than trying to help someone who is recovering from a disaster where all of their life and all of their relationships have been disrupted. And I would say in that first meeting, sometimes it is more important to actually build that trusting relationship than to focus on whether this person needs to be on a medication or if this person needs this thing or the other thing. Because once that trust is built, then the ability to actually implement things becomes that much easier. I've also gone through this list and highlighted certain things I think that are particularly important. One, the first is understanding your client and the situation your client is in. The second is understanding the community that this person is either coming from or the community that this person is lost. And that community, for example, could be the city of New Orleans, or that community could be this person's church, right? So these are things that become very easy to start to focus on in developing that first set of trust. Acknowledging the loss, and doing what you can to hear and to listen to the specifics of what those losses are, so that you can start to respond to them. Be reliable and show up. If you are going to be dedicating yourself to helping in the efforts in recovery and participating in resilience, make sure that you've made the space in your life to do this on a consistent basis, because other people are depending on you. And doing what you can to acknowledge your client's strengths. No matter how bad the losses are, if that person has found the internal strength to actually show up and say, I need help, then that person has a basic level of resilience that needs to be identified and responded to and supported. Now, when it comes to organizations or agencies that are going to be implementing programs like a collaborative care program, there are some values on that level that I think are important as well. The first is, be aware of your organization's resources. I mean, it's listed here as, needs, capacities, and limitations. But if you're an organization, for example, that does not have primary care providers as part of your network, then, you can't say that you're going to offer primary care services. If you're in an organization, for example, though, that has a large amount of people who can function as care managers and care coordinators, then you become valuable to another organization who may have, primary care providers, but no way to actually proactively reach out to the community, and you can partner up. So that's what I mean by that. Also, be aware of what your individual capabilities are when it comes to any one of these collaborative care tasks. So examples, there are various different ways of doing follow-up. For some, it may mean using the telephone. For some, it may mean walking out into communities. For some, it may mean using a computer to keep track of data. For some, it may mean using pen and paper. Just, again, be aware of what your organization resources are and what you're really good at, and have the confidence of knowing that you could contribute to a collaborative care model based on what you have. And then when it comes to doing, individual follow-up, I would say do your best to actually keep it as direct and as simple as possible. Sometimes the mere act of saying, hey, were you able to follow up with a therapist, can give you a whole lot of information, and you don't need to think very more complicated about it than that. So what's listed here on this slide is it's small. It's small and it's tiny, but it's really meant to communicate that when it comes to an organization view of how to participate in collaborative care, the collaborative care model is all about resources, and the collaborative care model is all about people with specific sets of skills. So you can see here that there's a ranking here of possible types of staff and types of activities that are performed, the level of training that's required, and the types of activities that go with that activities that go with that. And you can see that from least to most, where it comes from level of training required, you'll probably see that at the bottom at the most, we're talking about your mental health providers, primary care providers, and so on. These are probably the resources that are probably least available. And at the same time, the folks toward the top, where they're the outreach workers, community members, and things, folks like that, those are the resources that may be the more or most abundant. And I would say that organizing those in a way that really works with the collaborative care model is actually the core of how to build resilience, in a community using this model. Knowing that anyone in the community can actually be available to participate in ways that are helpful. As long as they have the willingness to learn and the willingness to be consistent and to show up consistently. Okay, so the next few slides are going to be specifically on some of the tools that you're going to be available to you uh, uh, as agencies and individuals that are participating in CLearn. Um, uh, so the first is this book called Beating Depression. And I think there are certain handouts that are going to be available as educational tools for your clients and your patients as well. And the book is actually organized very well, very nicely into chapters that kind of goes through the stages of, what it means to try to help someone identify if they're struggling with depression, for example, and then is it serious enough to require some sort of clinical intervention, and then how to go through that. Um, and very much this book is organized in a way that it also very much aligns with some of the way that the CLearn Collaborative is going to put together resources for you to screen for depression, identify folks, use the resource guides, and so forth. I would say that one of the important things to recognize here is that although we are approaching this collaborative care model from the perspective of depression, very often it's not only just depression, or sometimes it may not be depression at all. It's important to recognize, particularly in a post-disaster setting, that folks will be struggling with PTSD, anxiety, adjustment, but whatever it is, as long as there's a consistent process in place to actually help screen and identify, and as long as you as an individual and an agency are actually implementing those values that I spoke about before, about being culturally sensitive and building trust, you will have success in actually helping someone identify what's not working and helping them identify what resources they need and then how to help them get better. So I'm recognizing that I think for all of this talk up until this point, I've been talking about this from the perspective of depression, and we're going to be talking about depression a lot in the sessions coming up. But I want to give you the reassurance that this system of approaching care is successful for folks who are struggling with other things other than depression. Okay. The next set of slides here I'm going to talk briefly about some of the specific tools that you're going to have around going through the screening and some of the follow-up stages. So the first is this getting to know you worksheet. And honestly, for a lot of you, who are serving your communities, this worksheet can be is going to be worth gold to you if you're able to get it done consistently, particularly in a post-disaster setting where you're trying to find people, where you're trying to locate people. Where if you are able to find and locate people and you have this set of information on them, you will start to be able to efficiently, give care in a way that's sensitive to identifying where this person is at. Right. So you can see one of the things on this getting to know you worksheet is, my experience with treatment, check all that apply, and recognizing that people have, everyone out there has varying levels of experience getting mental health care, also has varying levels of trust, when it comes to working with a mental health system or working with a medical system for that matter. So being proactive now in terms of, screening in your community, getting to know your community, having a set of data that you can refer to pretty quickly, using this type of sheet would actually be very helpful. This would be one of the things that if you have designated someone as a care manager, this would be one of the tools that they would be using. I'm sure a lot of you have now heard several times of this PHQ-9 questionnaire, or this patient health questionnaire, and it's specifically designed to actually screen for depression. And it's also specifically designed to help follow response to treatment for depression if it is engaged in that way. I think the other way that this is also very helpful is that it also helps in communication with someone. One of the things that was very helpful for me when I was doing work with the Regional Project was that everyone has different language for depression, and some people are not very happy with the label depression, because that is what it is, a label. But if you look at this PHQ-9 form, it really gives you a way to actually talk to someone very clearly about specific symptoms that they're having without having to mention the word depression. And sometimes that alone, that ability to do that, would actually help a person recognize that you're actually hearing what they're saying as opposed to giving them a label. So that's another place where the PHQ-9 is helpful. I had mentioned before, this idea of having a registry, particularly if you're a care or case manager who is following a bunch of people. If that is going to be your situation, it is helpful to have a reliable way of actually keeping track of data. Because if you're able to do that in an organized way, you'll be able to see what people's trajectory is over time, whether they're improving or not improving. Or if you find that you have a lot of missing blocks or missing pieces of this data, that in itself can be really helpful information to say, hey, this is someone that may be struggling, getting in contact with me, or me getting in contact with them. What else is actually going on here? And it will prompt that it'll prompt that investigation into figuring out what's really happening. One of the things that we hope over time, is that with an implementation of a collaborative care model, that any patient or client that participates will actually start to experience improvement. Now, one of the I mentioned, in the very beginning, this thing called the IMPACT trial that did the testing around the collaborative care model. And one of the things that I didn't mention was that not everyone that went through that study actually took medication. Some people took medication, some people did a medication and psychotherapy, some people did psychotherapy alone, some people didn't do any medication or psychotherapy, but simply just really wanted someone to follow up with them on a regular basis to see how they were doing. And regardless of how a client or patient decided to participate, what the study showed was that across all those different ways of participating, everybody experienced a significant improvement. So one of the things that it becomes helpful then to think about, with the C-Learn project is that everyone is going to have varying levels of comfort with certain types of interventions. It is not your job to make somebody do a particular intervention, even if you see that they could be helpful. It is actually your job to keep that person connected to you and connected to care. And the idea that having someone who is available just to follow along, just to check in and say how you're doing, just to check in and say, hey, how's your family doing? Did you get to church this week? That type of thing. Over time, it's actually very helpful. The other thing that's also very helpful is that once you've identified that someone has actually gotten better by subjective and objective measures, writing down what are those things that were used to actually help this person get better and have that person hold on to them. For a couple of reasons. The first is, when it comes to depression, we know that depression as an illness is something that recurs, particularly if somebody is under stress. So anything that we can do to kind of remind a person what are the things that were helpful and successful for them is important. And the second reason is, if you're able to identify these types of things that helps a person get better and actually reflect back to them or give it to them in an organized fashion, they become that much more self-empowered to actually bring about their own improvement should symptoms start to show up again. Now, the other thing here that I've been by doing my best to emphasize during this session is that, again, different organizations have different resources, and the collaborative care model actually allows for you to actually tailor that model and your participation in that model based on your resources. And so this is a form that could actually be used, pretty readily to give you a quick glimpse of what your organization's strengths are and what you can offer to other organizations or agencies to participate in the collaborative care model. And one of the things that I loved about my experience in New Orleans during Reach NOLA is that you all really know how to celebrate life, even in the midst of tragedy. And one of the things that I would really want to emphasize here that is really important is that you as people and organizations that are going to be participating in this collaborative with C-Learn is that you translate some of that into taking very intentional care of yourself. So I'm going to give you some suggestions, and some of these suggestions are actually based on the things that I usually take for granted in my own life and forget to do. So the first is, make sure you drink at least 2 liters of water every day. I know this, and I know it sounds kind of basic, but I know for myself, if I don't do that, I don't feel good, and my energy level kind of wanes. The second is to make sure you eat at least 2 balanced meals a day. I'm not a breakfast person, and not everybody is, but sometimes when we forget to eat breakfast, we forget to eat the rest of the day too. Again, this is about making sure you have the energy to do this type of work. The third is do your best to actually take a 15 or 30-minute walk every day, if only to give yourself a mental break. And of course, the cardiovascular benefits are actually really, really great. If you are in mental health care, make sure you take care of that, right? So you keep your appointments, you take your meds, and you see your therapist, do all the things that you're supposed to be doing to take care of yourself so that you're available to take care of others. The other is sleep. That's something I struggle with. I feel like my mind is always active when I try to go to bed. I feel like there's always something to do, and I literally sometimes fight sleep, but sleep is important. The next is, find ways to purposely acknowledge the places and the people in your life where you feel grateful every day. Just try something, to me. So I guess it's my version of saying, do a gratitude journal or whatever. It doesn't have to be a journal, but if there are moments that you can actually take during the day to be grateful for the experiences and the things that you have, that really helps. Prayer and meditation, if that is something that you do, keep doing it. And I guess also, the last one I have here is, tell a loved one that you love them. Don't wait for a disaster, to do that, because, doing that actually kind of reinforces for you your own resilience, and kind of reminds you of the gifts that you have in your life that allows you to give and add in this way. And finally, I just want to remind you that, the C-Learn Collaborative is actually really about, again, building community resilience, and that there are a lot of people that are working very hard to provide you with the resources to support this type of work. One of those resources is www.clearn.org, and on there you will find a number of tools when it comes to depression and other things about creating resilience communities. And with that, I want to thank you, and I will look forward to talking with you next week for session 2 on depression and problem-solving therapy.
All right. Thanks, Wayne.
Sure.
We have a couple minutes left. Does anyone have any questions about any of the material that Wayne went over? And I do want to reinforce, because he did a really good job of reinforcing that, no matter what your organization is and what services you offer, there's always room to make this collaborative care approach fit within the work that you do. And so those screening tools that he mentioned, the book on depression, that stuff will be uploaded onto the C-Learn website, where you all access the recordings. So be sure to check that out sometime after this webinar when I post everything. So were there any questions? Perfect. So those of us in New Orleans have survived the tornado warning. So I'm glad that you.
Oh my gosh, yeah.
So I will see you all, or we'll chat again tomorrow for our disaster session.
Okay.
So take
and before we run, also I just want to, I guess I didn't say this before, but if at any time after one of these sessions questions come up that I can be helpful answering, please reach out to Ashley. And Ashley also has my email. Feel free to send me an email. I'm happy to respond to anything between sessions as well.
Perfect. All right, everyone. Have a good day.
Okay, thanks.